I will show some post-operative specimen and discuss about the value of cardiac surgery and accurate diagnosis of congenital heart disease by pediatric cardiologists. First of all, I have very interesting news from the clinician that there was a very successful story of congenital cardiac surgery. This is not the case, but I will show shortly the successful case. This is a heart with double inlet left ventricle, which means there is a rudimentary right ventricular chamber anteriorly located, and aorta is connected to arising from the rudimentary chamber. As you can see, the aorta is in front of the heart, and the outer chamber is of right ventricular morphology and has a communication with the main chamber of left ventricle type through this opening, which may be called VSD, but is rather interventricular communication or bulboventricular foramen, because it is a kind of outflow tract, subaortic outflow tract. And left ventricle underneath this chamber is like this. So we can clearly see two separate valve, well-formed separate valve from each atrial chambers. So this is one AV valve, and the other AV valve is here. So it was very nice to see this single ventricle with reasonable size and good function, and possibly it would be a candidate for ventricular septation and biventricular repair or Fontan operation if you think it is a single ventricle. So at this time, the surgeon first tried to make a ventricular septation to this line. This is the remnant of a surgical procedure, this line, to make a ventricular septation like this. And the opening to the outflow tract was here to show the aortic outflow. So if you make a septation in this line, it's very lucky to have a left atrial blood flow to left-sided part of a single ventricle, and right ventricular blood flow comes to this right part of the single ventricle, and we can produce pulmonary outflow tract in the back, or we may produce conduit from the outside to make a connection. So in this case, it is a good candidate, but during surgery, the surgeon found it was not really possible in this particular case. So the surgeon transformed the operative procedure to Fontan operation to make a cable pulmonary anastomosis, and these together produce a single aortic ventricle. But in other case, he is still living after 35 years after operation, and our Dr. Kim Soo-jin is carrying this patient, and the original surgeon was Dr. Park Pyo-won. He is also still working cardiac surgeon in this adult cardiac surgery. I could get the CT scan of the current patient, which was operated in 1987, and he is still very relatively well until currently. So this is the heart, very similar to the previous case. So this is aorta. This is rudimentary right ventricular chamber in front of the atrial septum. So this part is same, but the difference is that the right atrioventricular connection and left ventricular connection is here, and opening to the rudimentary chamber was on the right side. rather than left side in the previous case. So ventricular septation was made in this plane to make left part of main chamber and right part of main chamber. So now it became a kind of transposition, complete transposition heart. So the atrial blood level, the surgeon may produce the sending operation to make SVC and IVC join to the left-sided atrium and IVC to left-sided atrium, and pulmonary vein to the right-sided atrium. So sending operation and ventricular septation was a procedure performed 35 years ago, and he's still rare. So now the problem is that we have the patient has some history of arrhythmia problem, which can be treated medically and interventionally. And also pulmonary hypertension is present to produce big pulmonary artery, as is shown here. So this is left part of main ventricle. This is left appendage. This is left coronary artery. This is purple violet color is a coronary sinus, which drains cardiac venous blood to right-sided atrium, to which is a systemic atrial chamber, but this cardiac venous blood is draining to the right side. So I was very much impressed to see this case that this kind of difficult operation was successful, and he could escape from the Fontana procedure, and biventricular repair was well maintained for 35 years now, and he's still relatively well. And if you examine more carefully, I produced this model that it was printed in hard tissue, but the same heart is printed in relatively movable tissue to show the sending connection is here. This is SVC, and it connects to left-sided AV valve in between. So I don't think it's clearly visible from your side, but now it was originally connected to right-sided atrium, but now it is connected to the left-sided atrium to have a tunnel of SVC draining to the right side, and so on. So this is a very good example of the biventricular repair of single left ventricle. And that's what I want to show, because it was a recent case. I was very much impressed, and I would ask the pediatric cardiologist 35 years ago who diagnosed this case, Dr. Lee. Could you comment on this?
I think I remember these patients because at that time I was the pediatric cardiologist at Sejong. This patient was about 10-year-old boy, and our first septation patient. Yeah. Dr. Park operated it, and together with the concomitant sending operation was done with the septation. Actually, the patient had a good 2 AV valve and no obstruction at the time, or rather has a slightly pulmonary hypertension there was, but not the Eisenmenger state, and has a little bit large volume overloaded heart. So that makes the septation possible.
All right.
And the AV valve is not straddling or crisscross and functioning well. And you can see that more the systemic ventricle. So aortic ventricle is slightly larger than the pulmonic ventricle. That's when you do this one is done by one-stage septation, and the non-contractile septum, if you have the systemic ventricle has a compromise in pumping power, so we need a little bit large LV end diastolic volume. So surgeon usually do the asymmetric septation is better for long term. So I think that is one reason why two ventricle size is different. And I think Dr. Kim followed this patient during last 25 years or more. So she knows well, because I think the septation was successful, but the atrial flutter may be due to the extensive atrial operations, any operation, I think. And so in most of the institute, Fontan was the sole medical, solution for the univentricular heart. But in very selective case, something like this patient, maybe the septation is one very good alternative in very few, very, very selected cases, I think.
Yeah.
Yeah. Do you remember this patient?
Do you have progress on this patient?
Dr. Kim?
Question.
Yeah, I'm Dr. Jeong-Wook Kim from Sejong. I searched the CAS data before, and it's amazing. Even double inner left ventricular case, severe pulmonary hypertension, pulmonary vascular obstructive disease state, septation was successful, and living now at the age of more than 40. So this is amazing. But if I meet this kind of patients, and now can I try the same thing or not? I may not. But so it's amazing. So I'm curious about that. It's a mango state, but there is no hole between atrium or ventricle. In Alzheimer's state, after the total correction, it's just like primary pulmonary hypertension state. So it's very risky.
But that if you have pulmonary hypertension and high RP, we cannot do the Fontan too. There's no option.
I mean not the Fontan, but if you made a septation, we should make a hole into atrial septal or another space for the safety to make cardiac
a little bit late in age.
So I'm curious about the postoperative state at that time. Is it smooth, or you may not remember that? It may be very difficult postoperative course. And also one curious thing is now the right ventricle is too small compared to the left ventricle. The subpulmonic ventricle is small, but it works as a pulmonic pump, even though the pulmonary resistance is very high. So it's amazing.
Yeah, and we have done another septation to died. That patient, I remember, has a very friable septum and caused a paradoxical motion and caused outflow obstruction and died. And but if that patient came earlier nowadays, it's a good one reasonable alternative doing the two-stage septation. In that case, it would be better. But at that time, Dr. Park did one-stage operation, probably through the atrium, I think. Yeah.
As I remember, Dr. Yongjin Kim also tried the septation. How about your experience about septation?
Yeah, more than 30 years ago, I made several cases of septation, but the septation procedures are well reported by the Japanese Dr. Imai group, but in Europe or America, North America, there's actually no much reports. Nowadays, as I know, the function of the ventricular septum in the normal heart. So I don't like to make a septation nowadays because the many problems. Ventricular function, we have ventricular septum is very important. So the ventricular septum itself we made, such as patch, doesn't work and eventually fail. So in this case, there's no option. But I don't think it's very well done. We can, in this patient, we can make kinds of something, probably bending like that. We can breathe more than I don't know.
Do you think this patient
septation
do a Fontan possible after bending at 10 years of age?
I don't know.
Yeah.
I don't know. We don't know the answer.
But we know that, yes, in most institutes nowadays, the Fontan is the only postsurgical option.
So it's very difficult to do Fontan in this patient.
Yeah.
Yeah.
Very lucky.
But we still have multi-organ failures long time after Fontan and so on. We know a lot of problems with Fontan. So if we select, very clear, select the patients, maybe few patients, the septation is possible.
Very difficult to
identical physiology in that case.
To be commonly used is very difficult.
Yeah,
Okay, go back.
yeah, it is clear that it's not a simple case, and we need to discuss more and more. But and also it is not very clear whether this is a correct surgery at the time. But his life shows a kind of some message that Fontan operation and septation biventricular procedure have some advantage and disadvantage and so on. And also this pulmonary hypertension may be present already when the septation surgery, and which may be the reason why the septation is preferred than Fontan operation at the time. But after septation, the pulmonary hypertension may not progress, but stationary until now. Or the current problem still is the pulmonary hypertension. So it will be written in paper by the people currently managing, and those surgeon and cardiologists together when they decided to do this operation. I hope we will continue discussion on this case next time, someday. Thank you again, Dr. Kim Soo-jin and Dr. Park Pyo-won, Dr. Kim Sung-ho, and Lee Heung-jae all managed this patient and cared this patient until now. And also today's topic is the very difficult operation for complex cardiac disease. One of the topic is Jaten operation for complete transposition. So as you know, the Jaten operation is nowadays is a kind of standard operation operative procedure for babies with complete transposition. But it was not always true when 20 and 30 years ago. So I'll show some examples of complete transposition and failure of operation at that time. That doesn't mean we are still doing that mistake, but we are learning from those mistakes in 30 years ago. This is a classic view of complete transposition with intact ventricular septum. As you can see, this is right atrium, this is right ventricle, this is left ventricle. I made an incision on the right-sided ventricle and left-sided ventricle to continue to the anterior right aorta and left posterior pulmonary artery. So in this case, systemic venous blood comes from the right atrium to right ventricle and to systemic aorta. And pulmonary venous blood, oxygenated blood comes to left atrium, left ventricle, and pulmonary artery. So there has to be some communication between the two different systems. So when the patient is detected early in neonate, we can make a switch operation for this patient. But until then, we may need to make a balloon or blade septation to produce interatrial communication. In this particular case, there is an incision line in the atrial septum that this is made artificially to produce interatrial communication to wait until the cardiac surgery is done for the switch operation. But it was the patient died before the operation. So this is atrial septostomy site, and this is right-sided ventricle with intact ventricular septum and coronary ascending aorta. And left-sided pulmonary artery is a relatively good size, similar size to ascending aorta. So it is a very good candidate for switch operation and we have to check about the coronary artery distribution to prepare the relocation of coronary arteries from this anterior aorta to posteriorly relocated neo-aorta. And so the anatomy of coronary artery is studied by echocardiography and so on before surgery. So then I can show some operative specimen of complete. Yeah. This is a case of patient with switch operation. So this patient, in fact, the operation was successful, and the baby lived more than 1 year, but died of left-sided heart failure. So from the right side, we can see the right ventricle connected to neo-pulmonary artery, which was originally in the back of this main ventricle, but it is relocated anteriorly after relocating anterior aorta to produce a neo-aorta posteriorly located arising from left-sided left ventricle. As you can see, the right pulmonary artery is in front of the ascending aorta, which means Lecomte maneuver to make the relocate ascending aorta between the left and right pulmonary artery like this. And also the relocation of original coronary artery to posteriorly located neo-aorta is a critical surgical process to make this switch operation completed. But in this particular case, at that time, the coronary artery relocation procedure may not be completely successful, but made a kind of stenotic blood supply from the ascending aorta to the coronary artery that the left ventricular subendocardium has fibrosis. That means diffuse global and relatively mild ischemia produced insufficiency of blood flow to left ventricle in the anterior and apical part of left ventricle, like subendocardial ischemia, and that produced left-sided heart failure and dilatation of left ventricle. You may you can see the mitral valve is here, and the size of mitral valve is relatively small compared to the main ventricular chamber. Because you are looking at magnified view of this heart, you may not know whether this left ventricle is big or right ventricle is small, but the answer is left ventricle is big by comparing the size of mitral valve. Mitral valve is this size, and left ventricle has to be not this big, but it has to be smaller, and by comparing this right ventricle, the left ventricle has to be about this size, so that this left ventricle is interpreted dilated in this patient. Of course, you can say compared to the thoracic cage, the left ventricle is enlarged. It is simple for a patient, but from the imaging, you may compare the size of ventricle relative to the right side ventricle or mitral valve or aortic outflow. So we could not demonstrate which coronary artery was narrowed, but we can say based on the morphological, the end result of this left ventricle, and now we suspect the coronary arterial connection was not complete, but relatively insufficient to this blood flow. Yeah. Professor Kim, do you have any comment on that?
So can you see the cause of the ischemia or left ventricular ischemia? So the problem is the coronary artery transport?
We don't prove that, but we think based on this morphology, we think coronary arterial insufficiency can be the cause of this left ventricular failure and left ventricular dilatation. If you want to prove the coronary artery insufficiency, we may make a coronary arterial cast or coronary arterial angiography even after autopsy, but we couldn't do that. But we can just suspect the cause of death is coronary arterial insufficiency based on this morphology. If the coronary artery was completely obstructed, it has to be transmural infarct. But that's not the case in this patient, but it's a relatively mild stenotic coronary artery could be the cause of death in this patient. So it's very difficult operation, and even in the early postoperative period was successful, the end result may be disappointing, like in this case. Another example of operation is like this, and this case has a complete transposition with VSD and pulmonary stenosis, VSD. And in this particular case, this is right ventricle, this is left ventricle, and right ventricle was normal, and there was a VSD, patch closed, and there's a pulmonary artery. You may already see this pulmonary artery is bigger than expected. So pulmonary hypertension was present when the operation was done. And also the aorta originally located anteriorly was displaced posteriorly, and posterior pulmonary artery is moved anteriorly to locate here through the short conduit between the pulmonic valve to pulmonary trunk. On the left side, we are looking at the left ventricle. And again, we have some thinning of left ventricular wall at the middle to apical part of left ventricle, similar to the previous case. So it also imagined that coronary arterial blood flow is insufficient in this particular case. Maybe this patient was severer than the previous case, but the But if you look at the anatomy of the complete transposition with VSD, we are looking at this part that the original pulmonary valve, now aortic valve, is like this. So 2 and 3 leaflet aortic valve was present in posteriorly. But you can see this outlet septum is hypertrophied and located posteriorly to make a subaortic, subpulmonary stenosis before operation, and now it produced subaortic stenosis. And posteriorly displaced outlet septum with endocardial thickening is shown here. And this is original VSD, patch closed. So before operation, left ventricular blood flow was to the pulmonary artery, aorta, original pulmonary artery, and through this opening, the blood flow went to original aorta to make efficient mixing of blood from the left ventricle to aorta to produce good, relatively well oxygenation of systemic function. And subpulmonary stenosis was mild before operation, and that could also was helpful in this patient. But I could find this pulmonary artery is dilated, and it may be, I don't know why this pulmonary artery was dilated at this time, maybe post-stenotic dilatation, because in this case, before operation, pulmonary artery blood flow was not increased, but is decreased due to subpulmonary stenosis. And
what was the age of operation?
Age of operation. It's 9 months old.
9 months.
Yeah.
Do you think but the VSD is large enough for doing a kind of artery or something like that? It looks a little bit restrictive.
History shows Jaten operation at 3rd day of age, at age 3. And died after 9 months.
That means it's another surgical death, or
Yeah. So he was operated at age 3 days and died 9 months. So maybe this pulmonary arterial dilatation was.
the subpulmonary stenosis doesn't look severe.
Oh, no. Sorry. I made some mistake. No. It was 2 years and 10 months.
This operating time was the 2 years, 10 months. He died or?
Yeah. Sorry, I read another bottle, but this patient was 2 years, 10 months. So maybe this is that immediate after operation. That's because the heart is big enough at this time, and the left ventricular failure is already present when operation. Yeah. Can you? Yeah. Yes. The surgeon was Hanjejin and yeah, VSD arterial operation and VSD muscular outlet restrictive type, pulmonary valve stenotic. So I apologize for misinterpretation. It was there was a left ventricular dilatation and the dysfunction already present at operation. And maybe it was too late to operate this complete TGA with pulmonary stenosis and VSD at age 2 years and 10 months was too late.
What will you do when he comes to at that age in this morphology? What would you like to?
Let me see the pulmonary valve. You said that there's. I think that there's no pulmonary stenosis.
No, not really. Yeah. Maybe although the morphology is the posterior deviation outer septum, maybe the pulmonary blood flow has already been increased to produce.
I don't think it's actually the MPA dilatation may be caused by the pulmonary valve stenosis.
Uh-huh.
No,
Yeah.
this patient doesn't
So
have.
we do not know the severity of total RV, the stenosis level. But the VST size looks a little bit restrictive for doing Rasteria or something like that. What is the surgeon's mind? Dr. Lee, what will you do now
Back to
when you see this kind of patient at that age?
you know in this specimen you see there's no pulmonary valve stenosis,
No stenosis.
right? Dr. Sir, is
Yeah.
right? No
Right.
stenosis.
Maybe
No
they
stenosis.
relieve it at the operation. I
This
think.
is a patient
They
of
widen
TGA
at
VSD.
operation, I
No, you
And
cannot
at the age
widen
of
the.
more than 2
Not
years,
doing the,
Yeah.
when
the
they are
patient has
doing
already
operation is-
pulmonary vascular
Switch-
obstructive disease state.
Right.
조금 덜 풀 수
So
있다.
in TGA VSD, pulmonary vascular obstructive disease can occur even 3 months or 6 months old. So 2 years is too late for switch. So palliative switch may be okay, but the total is not okay in this patient.
Yeah, that is pulmonary vascular resistance, whatever. So I think the pulmonary valve stenosis is not actually no pulmonary valve stenosis.
Maybe
Right.
not severe PS, but even with a very mild pulmonary valve stenosis, sometimes cause the turbulence. So MPA can be, dilated. So we don't know the exact data now. So
Yeah. So I finally I'll conclude this case was original pulmonary valve was not stenotic, and VSD is present, and the pulmonary blood flow was increased so that pulmonary hypertension was already present at this age 2 years and 10 months. So it was not really candidate for switch operation at the time. And also left ventricle has poorly functioned already at this time. So it was not the candidate for surgery.
But with pulmonary hypertension, why that LV is so thin, the myocardium? Yeah? It's very strange, yeah?
Pulmonary. Yeah, there may be some other reason to have this kind of left ventricular dysfunction, but clearly what we can see is a pulmonary hypertension okay, and left ventricular dysfunction okay, and VSD present. And so in this setting, it is not really possible. And unfortunately, it was too late to care this patient and so on.
The patient died immediate post-operative period, or the. I'm very sorry to ask you the clinical history.
Yeah, there is a short description, and there is no record on what day he died after operation, but there is no endocardial covering on graft tissue and so on. So it may be immediate post-op or very recent very early after operation, the patient died. And clearly, the left ventricular function was not good enough to maintain the systemic blood flow in this case. I'll show example of Nikai operation tried in 1985. So at the time, the Korean cardiac surgeon and cardiologist struggled to make better and better result for patient care. But one of the trial was a Nikai operation at the time in this particular setting. And it was also failed, but it is worth discuss about this case. And this is a case of age was important. Age is 1 year, maybe 12 months, something like that, with hypertrophied right-sided ventricle, and left-sided ventricle is also looks normal with large VSD. And pulmonary stenosis was present. So it is setting of a complete transposition with pulmonary stenosis and large VSD. So pulmonary arterial size is like this, and ascending aorta is like this. So not very different. So the pulmonary artery is smaller than ascending aorta this is pulmonary artery. So Nikai operation was designed to produce when this kind of setting of pulmonary stenosis with VSD, so that the aortic root was mobilized to displaced posteriorly to arise from the left ventricle and anastomose the posterior wall, and then anterior wall was produced by some additional tissue to close the VSD closure. So posterior part of the aorta was anastomosed to the original tissue, but anterior part is anastomosed to the patch of the VSD. And then the pulmonary artery was connected anteriorly by giving enough space for aorta posterior located from the original stenotic pulmonary artery. And then a little bit artificial tissue was added to make a good connection from the right ventricle to pulmonary artery. But this was not successful at that time. Any comment, please?
Another comment. I think I remember this patient, but not knowing much about it.
I'm Kitchen. I'm Changari, Sejong General Hospital. Actually, I don't know whether this patient had Nikai operation. It looks like a Restrictive operation, not Nikai. Nikai is okay.
All right. So you mean Nikai operation is it has to be more pulmonary stenotic and
actually Nikai we call the aortic root translocation.
Yeah.
So in these patients, I don't know exact anatomy was. So actually anterior position the aortic root moved to the posteriorly when it do the aortic root translocation. Is this patient's the case?
Can you see the left side view of the aorta?
Yeah.
Yeah, it looks like the translocation. You know, if the patient diagnosed the transposition of great artery before operation, it looks like some of translocation. If you see the
can you see some suture material between aortic root and the posterior side of the LV? So
I heard from Dr. Chef, who did this operation, just before I joined the Sejong, and he said he, mobilized the aortic root. Yeah.
Actually, tomorrow morning we'll present aortic root translocation in patients with CC-TGA, VSD, PS patients in tomorrow morning.
It's we call it translocation with various kinds of surgical technique, the half turn or the complete turn, right neck. So I don't know who operate this operation, but the.
So the reason the surgeon described Nikai means that this particular part is mobilized completely to make more space to the left ventricular outflow. So this part is sutured original position, but the surgeon thought it is not enough to. If we couldn't have this distance when we anastomos translocated the aorta to this position. So it was originally like this, but it is open wider, and to make a space like this. So the original outlet septum was removed at this area to make a Nikai procedure by his description. But what the current discussion means that that is not the original description of Nikai operation, but it is more like a Rastelli operation to make a translocation and the artificial tissue outflow tract inserted from right ventricle to pulmonary artery. This is Rastelli operation. That's what Dr. Lee Chang-ah is describing. So that can be discussed more tomorrow morning.
Yeah, thank you.
And I will show example of a corrected transposition from now on. And this is a 7-year-old man with dextrocardia and the left anterior side is ascending aorta. So this is aorta, and pulmonary artery is right posterior and smaller than aorta. In this case, systemic venous blood flow drains to right-sided right atrium and right ventricle and pulmonary artery originally, but I'll show shortly current connection model. And then systemic pulmonary venous blood drains to left atrium, left-sided ventricle, and ascending aorta. And left-sided ventricle is right ventricle instead of left ventricle, with relatively redundant tricuspid valve tissue between the left atrium to right ventricle. And subarterial infundibulum is clearly visible in this specimen, which is subaortic infundibulum. So systemic venous blood, the systemic venous blood runs to pulmonary artery, and pulmonary venous blood flow goes to ascending aorta. So it's a corrected transposition. And so ventricular arterial discordance and atrioventricular discordance, double discordance produced correction physiologically. And also we have VSD and pulmonary stenosis, which was already pulmonary atresia in this particular stage. Instead, pulmonary blood flow was maintained through this ductus arteriosus, which is long and tortuous at the below the aorta to connect to the left pulmonary artery or middle of the pulmonary arteries. So,
Yeah, Dr. Sir, the most surgeon would like to know the exact location of the conduction system in this corrective transposition. So would you identify on this specimen?
Yes. So I'll show the conduction system of this case that we expect AV node on the right atrial side like this. So this is orifice of coronary sinus. So no. In fact, it is not orifice of coronary sinus. It's a diverticular process, and there, in this case, there is no coronary sinus orifice. Coronary sinus was atresia of coronary sinus and persistence of left SVC. That means coronary venous blood drains to left SVC and through innominate vein to right SVC in this case. Anyway, this zone was reminiscent of triangle of Coho, but difference is that if it were coronary sinus, it can be a kind of tendon of Todaro is like this. But difference is that there is no atrioventricular septum in this case because this mitral valve is above the tricuspid valve. So tricuspid valve is here, mitral valve is now here, but tricuspid valve is around this. So atrioventricular valve is atrioventricular muscular septum. Atrioventricular septum was produced between this right-sided left ventricle and left-sided atrium. So there is no way to have a normal conduction AV node in this plane, but it is the AV node-like tissue is this part is separated from here, and the other somewhere here. So the AV node is displaced. These two that can be understood by looking at this view. That if AV node was here, it will produce this conduction. But AV node was there, it can be this conduction. But the AV node in this particular case is not easy to visualize. It's not possible to visualize. But by experience, we usually expect AV node is something like there. Of course, in this area. So AV node is somewhere in this zone, and then the His bundle-like tissue are produced to this reach to left ventricle, and sometimes to go the anteriorly to produce like this to this plane. Of course, on the right side, we expect it's intramuscular, but it is in front of the VSD rather than in the inferior margin of VSD. So this part is dangerous, and also by making this part is also it runs like this to make in front of the pulmonary artery to make that area. So if we this part, we in this case there is a coronary artery running in this zone, and of course no surgeon will try to make an incision in this plane, but this zone is also related to conduction pathway in front of the pulmonary artery and VSD. So if we need to make an enlargement of this defect, we must not damage the anterior part of VSD, but we may cut a little bit of apical part of this muscular septum.
So the nowadays in case of corrected TGA VSD, there's no person to operate conventional methods. So the we usually close the VSD through the right ventricle or right side atrium, left side atrium. So the you can see the from the left side atrium, the conduction system.
From the we can approach left-sided atrium not from the left side but from the right side to make an incision at Waterston groove. So this is right atrium, and this is this is left atrium, this is right atrium, and this is adhesion of pericardium. And if you cut in between left atrium and right atrium, this is Waterston groove. And by making incision in this plane, you can approach from inferior to the left atrium, like this. Expose the left-sided AV valve, which is mitral valve in the normal heart, and then we can see the this part is tricuspid valve, and this part will be the location of AV node, because this part is like this. So if you open from the right end of left atrium, we can expose like this, and then this part is location of AV node and conduction tissue, and also this part is location of VSD. This is VSD, and so from here, if you look up this part, we will show the VSD. So from the left side AV valve, we are looking at the anterior leaflet of tricuspid valve. So underneath this anterior leaflet of tricuspid valve, there is a VSD. So from the left side, we can lift up this valve and to make a switch operation closure of VSD from this view. So this is roof of left atrium, and by lifting up this roof, we can approach VSD like this. I make confusing you.
Confusing, you know. In the conduction system go up to the ventroseptal defect, you know.
Yeah.
Yeah, right?
Right.
Even though whatever the left or right.
So more cranial part than apical part. Yeah.
So why asking, you know, nowadays we don't close the VSD in corrected TGA's conventional method.
So you mean you don't close VSD through right atrium, but through left.
Nowadays, no, we don't close the VSD through the. We go to double switch,
Double switch.
Yeah.
Okay.
If you have a VSD. So it is very rare to close the VSD through the right ventricular side, through the mitral valve, right A valve. I mean.
Is it easy to approach?
And the problem of corrected TGA several. One is the kind of conduction tissue and operative the stenosis of pulmonary artery and VSD, and another is the Epstein's-like malformation of tricuspid valve, left-sided tricuspid valve. In this particular case, we have a kind of mild displacement of tricuspid valve and redundant tricuspid valve tissue in the left-sided ventricle. So there is some, you may already see the nodular thickening of free border of left-sided tricuspid valve, which means it is traumatized to produce nodularity and redundant valve tissue in this joint. This is a relatively good example of mild Epstein's anomaly, but in severe case, the displacement is more definite, and more and more severe case may harm the function of left side right ventricle to make function of this potential systemic ventricle work very difficult. And we have several cases of severe stenotic Epstein's malformation, but is available in the workshop, but not now. So we will have more cases when we have those hearts available next time. So these hearts are prepared for demonstration today, and I have discussed very unusual and very adventurous, successful case of single ventricle with biventricular repair, and then complete transposition and corrected transposition, and the rest of them are candidate for Fontan operation, but this is one of the example of Fontan operation. Fontan operation is really very long history of success and failure, and there is many the innovative change of this heart. In 1980s, there was a heart with classic Fontan operation, which was that the right atrium was used as a system pulmonary ventricle. That was possible when there is a tricuspid atresia or when we produce tricuspid valve atretic. So in that particular autopsy case, we could see superior and inferior vena cava blood comes to right atrium, and there is a connection between right atrial chamber to pulmonary artery. And at that time, there was some trials of valved conduit from right atrium to pulmonary artery and so on. But finally, we found that was not a good approach to make right atrium as a systemic chamber, because it's a thin walled and volume chamber rather than systemic chamber. So we no longer use that classic Fontan. But what we do is Fontan operation using conduit lateral tunnel type operation to make inferior vena cava blood flow anastomosed to pulmonary artery like this. This is extracardiac conduit, and some other examples, the right atrial lateral wall used for this conduit, which is a lateral tunnel type intracardiac lateral tunnel or extracardiac lateral tunnel. And also, SVC is drained to pulmonary artery like this. It may be unidirectional gland to the right pulmonary artery or bidirectional gland to right and left pulmonary artery from the SVC connected like this. And this can be single procedure, or it may be after bidirectional gland first and the next time to produce inferior vena cava blood flow to SVC. And also we can see this tubal connection between the right atrium to this channel that is a lateral tunnel. The fenestration, original fenestration was opening between the wall of the lateral tunnel to atrial chamber, but in this particular case of extracardiac lateral tunnel, there is no common wall between these two chambers. So what's the name?
Cortex?
Cortex was used to produce the anastomosing pathway between these two chambers. So there will be many things to discuss for surgeon and cardiologist about Fontan operation, but we have a limited case of autopsy specimens, and you will discuss with surgeon and cardiologist. Could you comment on this type of operation?
Let me see the ventricular cavity.
Yeah. In this particular case, this is the aorta was left anteriorly located. Left anteriorly located aorta, and main ventricular chamber was left-sided, and right-sided ventricle is small. And if you open up this right ventricle, it is left ventricle with a small AV valve to the right-sided left ventricle, and VSD is present, and atrioventricular connection was through this right-sided mitral valve, and left-sided tricuspid valve is here with mild displacement of tricuspid valve to the left-sided main chamber with VSD and anastomos to pulmonary artery. So it's a kind of corrective transposition, but with pulmonary artery outflow is small originally, but now it is disconnected from the pulmonary artery from this main chamber. So this chamber was too small to use as a pulmonary ventricle in this particular case, and it was operated by Fontan procedure. Do you think it's still possible to make the Rastelli type operation from right side left ventricle to pulmonary artery?
Yeah, I think it's a LV, morphologic LV, right-sided morphologic LV. I think it's small for biventricular repair. Yeah.
Yeah, it was relative to the left side right ventricle. Right side left ventricle is too small, and it is not enough to use as a pulmonary ventricle. Although it may become larger, but it's still good for biventricular repair.
What about the right-sided valve, AV valve? Is also hyperprosthetic?
Right-sided AV valve?
No.
Left-sided?
No.
Right side.
Left ventricle.
Left ventricular mitral valve is small, but relative to the ventricular size is not very small. So it's left-sided mitral valve may functionally normal in this particular setting. We may consider the biventricular repair because the pulmonary ventricle doesn't have much pressure loading for this case. So, but the cavity is too small, I think. So that was the surgeon thought it's not really possible to make a conduit from this John, or the pulmonary stenosis outflow originally placed here was too small and not easy to enlarge this pulmonary outflow at this original location. So there has to be some neo-pulmonary arterial orifice surrounding around here, but that's my thought. And it was 1998, so it's 23 years ago. So you may not remember this case, but it was discussed long time ago at the 3-day seminar. So maybe we can ask Dr. Kim Sang-ho, what's the difference between the old stage Fontan care and recent Fontan care?
Maybe it's, well, we have an interim procedure nowadays, but, you know, in mid-80s, late 80s, we don't have an interim procedure, and we don't know the exact pulmonary vascular distance. You cannot believe the castration data, and the
care too, post-op care.
Post-op care don't know about the ventral functions. And
I think in the Fontan operation, in the history, we have several big points. First one is stage operation, not direct Fontan. We perform a BCPS first, after then Fontan operation. And also, second one is we know the risk of the Fontan, so the first preparation is very important. If the pulmonary flow is big, we try the bending, and if it is too small, the shunting, or LV outflow tract is too small, DKS, something like that. So pre-Fontan procedure is getting better, and the stage operation. And the third one is making a fenestration for the post-op stage that is better. And as you can see, the material is changed. The hemashield is known as the good conduit. We use the Gore-Tex now because hemashield getting intimal preparation is too high. So that kind, and also the post-op care is amazingly developed.
In this case, the pulmonary artery looks a little bit small to me. Do you think it's enough in size for doing Fontan?
In this particular case, there was a BT shunt, original BT shunt removed at this time. So the pulmonary arteria was replaced, pulmonary blood flow was through this BT shunt first, and then it was converted to Fontan procedure. So original pulmonary trunk was here. Maybe, yes, it is. Maybe something like this. Maybe this is ductus, and original pulmonary orifice was here. It was almost atretic. So maybe mainly the pulmonary blood flow was maintained through the ductus, and it is replaced by BT shunt, and then Fontan procedure.
May I ask the size of a conduit?
This conduit?
Yeah.
Yeah.
And the patient, how old is he?
He's Yeah, it's 3 years.
3 years.
3.
So now you don't use this material no longer, but
Yes, actually, I don't have such kinds of. I don't use this such kind of material.
never used.
So it's a very, So what's the size? You can push your finger into
Yes,
here.
it's
Yes, more than 20. Actually, I think.
almost 20. Not little less than 20.